We are very pleased to have John Teeter with us. He is the former acting CIO for HHS, and it must be said, John has been with us. Many of you know, we actually, Kelly and I started another organization called the Government Technology Research Alliance many years ago, working with federal CIOs. John was one of our first council members there, and he was very instrumental in helping us achieve success in that organization, and then subsequently became one of our first council members for Health Tech. So he's very, not just a speaker today, but a very good friend of ours. As the former acting CIO for HHS, John was responsible for all aspects of information resource management, including several enterprise programs, which include information technology, strategic planning and performance management, IT capital planning and investment control, enterprise security, IT project management, and the development, maintenance, and use of HHS enterprise architecture. And with that, I'll hand it off to John.
Thank you. So as Parham said, I am the former Chief Enterprise Architect for HHS, the former Deputy CIO for HHS, and the former Acting CIO for HHS. And since I retired at the end of June, I am now beholden to no one and no organization, so be careful tonight. I no longer have to watch what I say. Right, Doug? Dr. Doug Frisman in the back is one of my colleagues from HHS. So, I guess let's just go ahead and get into this. And I might encourage you all too. Those of you that have heard me speak before and have been in different presentations that I've been a part of, I welcome your participation. So if you have at any time during my comments, if you have something to add or a question, I find that I learn as much from you all as hopefully you'll learn from my perspectives. So please, you know, if you have something you want to bring up, then please do that, because I not only welcome that, but it's good for me as well. So, what are we pursuing in healthcare? And I'm hoping that Doug is going to agree with this. So we're looking to reduce healthcare costs, improve patient care, improve health outcomes. Now, you might say that improved patient care and improved health outcomes are the same thing. I tend to look at them a little bit differently, because one is about the practice of care, serving the patient well, and the other one is more, for lack of a better phrase, more population-oriented, if you will, where you're actually improving the wellness and human condition of a larger population. To be sure, that affects an individual patient, if you will, but it's slightly different, and I hope you'll see that as we move on. And we want to increase accessibility to that care and to those potential outcomes. And so I'm going to ask you right up front, does everybody agree that these are the things that we're pursuing? These are the important things. Is there anybody that wants to add something for consideration? Yes, sir. I think that's a very good point, and I do have some comments in the presentation on that very topic, and I'd be interested in your thoughts at that time as well. Yes, ma'am. Okay, so something in the area of of standardization, and so that because industry does this very well. If they have a technical protocol that they put in place or they adopt in large measure across a particular or a selected market, then as they transition to the next iteration of that protocol, they build that in so that there's not a rip and replace that comes with a lot of heavy cost and to get the capability that you're saying. Is that what you're talking about? Okay, all right, that's good. I like that word sustainability. I'll steal that if I may. So, anything else? Okay, similar to what I've done, what are we pursuing? Then at the bottom, for all segments of the population, ... Okay, great. Okay, so have we reached a little bit of common ground before we go on? Okay, great, super. So let me just talk a little bit about healthcare costs. Depending on the projections that you read, and there's a lot of analytical work that goes on in this area, we can see a projection of healthcare costs increasing about 4% annually. In most cases, are the estimates. Some studies that I've seen show a 5.6% increase. Some of them have been as high as 7%. But the bottom line is that from now until about 2017, people are thinking that there's going to be an increase somewhere in the neighborhood of 4% annually or greater in some cases. So the bottom line is there's an increase in the offing. And the reason people use that 2017 where they start to pause in their projections a little bit is because they want to see the results of the Affordable Care Act. And so they know that that's when a lot of the things are slated to really, the full array is slated to kick in. And so with that kind of an increase, you're looking at about, I think the latest projection that I saw was by 2021, healthcare costs would approach 20% of our gross domestic product. And to give you an idea of that, I believe last year's gross domestic product was about 13.78 trillion. So if you have 20% of that, that's a big number for healthcare costs nationally. And so obviously this is a key point. We need to drive down the costs. And so and I'm going to suggest that the last few bullets will help us do that if we approach different tactical mechanisms in those last three bullets accordingly. And so let's go ahead and move on. And so what I wanted to talk about was if we're going to do those things that we agreed needed to be done, there's going to be some changes in practice. And some of these things are already underway, obviously. So electronic health records promulgation, Dr. Frisma has been working on this for a long time with the Office of the National Coordinator. So there's a lot of legislative requirement that certain things be done, and there's incentives to do this. But I would suggest also that it's not only the financial incentives to do these things, but the ability to effect care that allows us to do this or compels us to do this in kind of a coordinated way across the national healthcare spectrum. So depending on the study that you look at, there's anywhere from 3 to 13% improvement in care now for patients with targeted conditions. And an example of one of those conditions that requires ongoing review and attention might be a patient with diabetes. And so if you can improve that care by any of that percentage, whether it's 3 or 13%, and the reason it's so variable is because of the sample for the study and things like that. But you know, the bottom line on this is it is a positive, it is a known positive effect on care. And then if you look at things like electronic checklists for things like medications. You know, there's I think the figure is 27% fewer errors in medications and dosages of those medications across the patient community. And if you then start to extend that into the areas of things like immunizations and lab tests and lab results, you can clearly see where having that information causes a change in how you practice and provide health care. And so I think these are just some obvious things that we can look at, and I think that are probably apparent to all of you all. A couple of things also are the home health care advancements. Home health care is estimated to grow it's estimated at about $70 billion across the country so far. In the last, I think the last year or two, they've maintained a little bit of a stability. I think 2010 was when they actually hit the 70 billion mark, but I think that 2011 was actually in that 70 billion as well. Now, this is an area of change of practice that I think is greatly interesting, and that is that if you use various technologies that will allow people and patients, or let's just say patients, to retain their health care in a home setting, not only are they more comfortable as patients typically, but the estimate on this is that you save about $6,000 per episode of care in the home as opposed to if you had it in an institutional setting. And I think those estimates come from typical Medicare payments for institutional care settings or episodes. So that's a huge amount of money. And so if we can implement the uses of technology, whether it's different types of video technologies or different types of mobile applications or mobile sensors or whatever that we'll talk about a little bit later, then I think that is certainly a change in the way we practice the delivery of care. Telemedicine, similarly, and I differentiate that a little bit because home health care is a little bit different from the overall scope of what telemedicine includes. But telemedicine is also supposed to increase in the investments that are made in telemedicine by 25 to up to 25 or $30 billion by 2016. So these are big changes in the way we deliver care and seek to produce outcomes, better healthcare outcomes. And as you mentioned before, there is an increased interaction with patients through personal health records, mobile apps, different types of communication interactions, and that speaks to the experience, the patient experience, and we'll talk a little bit more about that. But those are some changes in practice that I see coming forward, and so one of the things that I wanted to talk about was to give you a few statistics on what I think is the patient experience is one phrase that I've heard. The other phrase is patient intimacy. And so patient intimacy, it's really interesting. There's a lot of studies that are being done on patient intimacy. And so a few statistics here. Again, there's a variety of these studies, but this kind of is a summary of some of those things. 80% of the patients that that providers deliver care to say that they would like to have continuous contact with their physician. 80%. But only 70% say, of that group, of that 80%, say that they have actually conversed with their doctor outside of regular annual physical visits or treatment episodes. So there's no ongoing experience. Yes, sir? What was that percentage? 80% surveyed said they would like to have continuous contact, but only 70% of that number says that they do, outside of normal treatment episodes or routine physicals that typically happen annually. So they're looking for more of a contact and more of a dialogue with the practitioners. 50% of those surveyed said that a reminder, had they had it in the past, could have prevented an adverse health event in their own personal experiences. So there's obviously a value in delivering better care if these patients, thought that they could have avoided an adverse event with such an interaction. And of those, 45% preferred to have that interaction via email, but only 19% of the providers that these people interacted with used email. And even less of the providers used smartphone apps, which is 4%, or text messaging, which is 7%. And so there's a need for this patient intimacy, a desire for a closer interaction. And I might submit that equates to a desire for the patient to be more involved in their care. They're interested in their care. They're interested in being a part of the dialogue. And so this is a shift. And some of this might be related to a generational shift because obviously, old dogs like myself who grew up, before the internet, they have a different perspective on technology and information sharing and information availability and things like that than the newer generation. Yes, sir.
Coming from abroad, I would like to know who have the incentives, who have to make the pressure for increase the home care, like you just talked about in the United States. Who have the incentives to make the change?
Well, that's a good question. I'm not sure who is actually incentivizing home health care. I think that in many cases, patients are asking for this. But when you start talking about incentives, I'm not sure that we really have a number of hard incentives that would drive practitioners in that direction. Now, the Affordable Care Act, I think, is starting to do some of those things because they have the concept of accountable care organizations, and so one of the ways that you can drive down costs and have a more continuous dialogue with patients that allows you to be more accountable for their care is having a greater reach into wherever their treatment is necessary. Does anybody else have any other comments on that? Yes. Sure.
Don't go to physicians who aren't up on the latest technology where they cannot send me emails, and I don't get these types of reminders. So I think that as the consumer, as with anything else, the market will drive some of these changes.
I think that's right, and that's why I said the patient themselves are typically asking for this type of an interaction, this type of a dialogue, and this type of technology to be available in their care. Yes, sir.
I was going to agree with Cheryl and say that the baby boomer generation, there's a lot of discussion about that, do not want to be There are a lot of studies now going on and demonstrations using paramedics to do home house visits when they're not on emergency calls. That's one area. A decade ago, we never heard of getting a flu shot at CVS or Walgreens. So using the pharmacist. So I think the changes in practice are also utilization of non-physician providers to do that, not only the home care, but the normal routine care. You go to the CVS mini clinic now and have your sports physical treat flu symptoms.
Absolutely. I mean, I just went through Easton, Maryland, and there was a big sign at one of the, I think it was at a Walgreens, 24/7 flu shots. I mean, you know, so availability is, and in non-traditional ways is actually, you know, becoming more of the norm. And I think that there'll be more patient demand for that type of accessibility of services, you know, where possible. Yes, sir.
Question about telemedicine. I surveyed a company in Canada called Ontario Telemedicine Network, where they basically, you know, because of the huge geographical location and the challenges of getting providers there, they established these tiny centers where the providers would be in major metro areas, and then there would just be nursing staff equivalent where the patient would go in the rural area and be able to interact with the physician. They provided some technology to do that. But you quoted a number that in the U.S. that's going to grow up to 30 billion or what have you. And my understanding of it was there's a lot of regulatory challenges with that. For example, dictating that the provider has to be physically in the same room as the patient in order to be able to bill for X services. So can you elaborate on that? Do you know something about regulatory changes that are coming there?
I don't know about the regulatory changes that are in the offing, other than those things that are being supported by the Federal Communications Commission. Those things that are seeking to increase the availability of bandwidth and different spectrum availability that would allow for telemedicine to be done in a more effective way. The actual healthcare regulation, you're absolutely right. There are a lot of impediments to that type of an interaction, but I view those as being something that, as we talk about our vision for healthcare, those are the kind of things that we'll have to take on and that we'll have to address. And I know that, you know, that we have an organization within the Office of the National Coordinator for Health Information Technology at the Department of Health and Human Services that takes a look at all of those types of things and seeks to remove such obstacles. But I just don't know exactly which things are in their priority scheme right now. But you're absolutely right. Yes, ma'am.
I was going to say to this question, this gentleman's question, you know, the Center on Aging has had initiatives for the past couple of years looking for innovations to reduce costs for home health, and which impacts, you know, of course, the readmission rate in the local areas. So the thing that they're spending, that I think is a win, is that, you know, if hospitals can find those solutions to reduce readmissions, those innovations are probably getting solutions for home health.
I think that's absolutely right, and I would be remiss if I didn't refer you to the website that they have, because they have a lot of resources for various alternative types of care and in-home care in particular, and the concept of home health nurse or something like that, where they come in. So there's a number of things that are starting to evolve in this area with great focus on the quality and the comfort of the patient, because obviously the patients are more comfortable in their own home setting. Yes, sir.
One of the challenges is that as we put more of the responsibility on the patient, how do we also then give them the incentive and the penalty by not adhering to that? So if I'm a diabetic and I don't have to manage my sugar over the years and get retinopathy or cardiovascular disease, what price do I pay? So instead of paying, you know, penalizing providers and taking their reimbursements away, if we're going to put the focus
I think that's absolutely right, and I think that that's part of that future discussion, figuring out these types of questions about, if you're going to have accountable entities, that entity could be a patient population, and it also could be a provider population, and they have to work together. And I think that's one of the future changes in the delivery model that we're gonna see. Yeah, yes, sir. Yeah, I think that's right. And this kind of goes back to your patient experience comment that, if we make this easy enough and valuable enough to maintain this dialogue with their physician or whoever their care provider is, then we'll get better results. And I think that, just as we see on all of the websites nowadays, everybody looks at the usability of the websites. How many clicks does it take to get to the most relevant information or the information that people are looking at? We need to do the same type of thing as we address the patient experience as well. Yes, sir. Mm-hmm. And that's exactly the challenge, isn't it? So that we have to make this workable. We have for all participants in the healthcare community, and so we have to show the value for the patients. We have to show the feasibility for the practitioners, and so. But along with those challenges come various opportunities. So when we start to talk about supporting change, you can see that there's a few things that are going on. So I mentioned the FCC, the Federal Communications Commission, that is involved in doing things like extending the use of various bandwidth into areas that are underserved. So you start to build out the infrastructure, if you will, that might support these kinds of things. They're looking at modifying their rural healthcare program to allow for consortia of healthcare entities to request additional bandwidth in targeted areas where electronic health records might be needed, but maybe the bandwidth for exchange of electronic health record information might not be sufficient to do so. And then they're also doing other things that are, and this is a very specific thing, they're working with the international community to do spectrum harmonization for things like medical body area networks. Are you all familiar with medical body area networks? This is some very great technology that I'm just starting to look into, and this is where you have wireless devices or sensors that are applied to a patient. So obviously if they're wireless, the patient is more comfortable, and you also then wirelessly transmit information, whether it's vital statistics or whatever, to the collection point. And so this is a new area where the Federal Communications Commission is actually working on this, and this is a great technology. I think it has a lot of promise, but it's kind of specific. The other area is this increased data availability and the big, we all know about big data management. But one thing that leads to this type of management, I think, is it goes back to the infrastructure comment. So if we're going to exchange information broadly, we need to have the infrastructure in place. But why would we even be concerned about big data? Well, obviously there's the opportunity to identify patterns that may affect wellness and care, and this is an area where I'm really interested in additional work being done by various folks, in the private and the public sector, and that is showing a correlation by the identification of these patterns between health conditions, adverse conditions, and maybe behaviors early on. Obviously, some of these things are very obvious. If you don't exercise and you have Big Macs every day, 2 or 3 times a day, then you're probably going to have some kind of an adverse effect in doing that long term. Now, that's really, I'm not suggesting that we go out and we analyze McDonald's, but I am suggesting that there are correlations that are discoverable across multiple areas of data that we may already have in-house. We just haven't figured out the analytical capability to expose those patterns. And then when those patterns are discovered, then we can affect behavior and resulting outcomes rather than patient care. But we can also affect patient care. Something that we've done in the past to use big data, or through the use of big data, is we've had a reduction in fraud and improper payments. You've heard CMS announce the billions of dollars that they've saved by doing this. So that's obviously an opportunity. One thing that I'm interested in us as a community doing is to start to deal with some of these things, like there are grants for states to produce various security strategies and solutions that would help in healthcare. I'm going to suggest to you that this is a great and wonderful thing, but we've got multiple people doing the same thing. And they're all coming up with a variety of solutions, and so we're still where we were many years ago. And so I'm going to suggest that this is an opportunity for convergence, so that we can now come across these domains of activity. So healthcare or health has certain security requirements. Energy has certain security requirements for exchange of information, transportation, law enforcement, et cetera, et cetera. So I'm going to suggest that we should do this one time, and this is a great opportunity. And I would implore you actually to participate in converging on a common solution here, because this is something that will stymie us from making progress if we don't address this. And even the federal government is conflicting with itself. They have the National Strategy for Trusted Identities in Cyberspace, where they seek to develop a universal or a shared authentication strategy and set of solutions. But then we're also giving grants to people to do other things and to come up with other solutions. So this is something that I've actually talked with the federal CIO, Steve Van Rokel, about. He's very interested in shared types of services, but these are the kind of things that are maddening to me. And I can say these things because I'm retired now. So anyway, so when we start to talk about data, and if you guys, my background is I was the chief enterprise architect for the Centers for Disease Control, and I then became the chief enterprise architect for the Department of Health and Human Services prior to becoming the deputy CIO and the acting CIO. And so one of the things that I tend to do is I tend to look at things in terms of changes in business practice or process, and then what we need to do in those areas to array our resources in support of that change. And so one of the things is data. So obviously there's an opportunity to harmonize data. And so you have the implementation of standard code sets, International Classification of Disease 10 as opposed to 9, although we're going to have to figure out the crosswalk there as well. SNOMED, Standard Nomenclature of Medicine, and then LOINC, Logical Observation and Indicators Naming Conventions. These are things that we can converge on and that people are already using, but we're not doing it universally, and we're not doing it in the same circumstances universally. So this is an opportunity, and I know that Doug is very interested in this. The Office of National Coordinator is very interested in this, and you see a bullet here. Actually, you don't see a bullet there. The American Health Information Management Association has recently, signaled that they would love to be involved in helping to develop a data governance strategy. And so I'm sure that, with those kind of things, once we start to identify the data assets within the context of the healthcare community, and then we start to discuss how we're going to discover and share those assets, then we can advance into more strategic thinking, like, so we have this data, we have this problem. This data helps us to support this problem, but we have gaps in our data. So now we can make strategic decisions on how we're going to apply our scarce and becoming more scarce budgetary resources to fill those gaps in a very strategic way. So now we're starting to actually do data management that supports our analytical priorities and potentially our research priorities. So this is a huge area of opportunity, I think. The federal government has said that, well, actually they haven't said, in November they will say, or they have said they will say, that data.gov will be the repository for all live government data and metadata. Now, I will tell you from the beginning, and again, I can say this because I'm retired, I was not a big fan of data.gov. And I have since become a believer in that necessity as a transitional framework. Because it has provided more access, it has provided more availability of data, and people have done some very innovative things with the data once they knew where it was and how to get to it. But my initial thought was that we should simply develop metadata standards that would allow us to more effectively publish the data that we were all producing on a daily basis, and let the commercial search engines help us to find that, because that's something that they do well, and that would not have required very much of an investment by the government at all. Now, as I said, I've since come a long way in accepting this as a necessary transitional activity, because it does make data more visible and more available. Yes, sir. Yeah, Yeah, I think that's a good point. And I didn't mean to suggest that we weren't doing this. I was just suggesting that these are the types of things that would support the change that we need in our practice. And another thing that you were from Denmark? I want to validate my a statement here that Denmark has signaled that it will follow the Continua Health Alliance development of health interoperability standards.
Yes, I think so. But I also agree in your conclusions that it's very important for instance, in the United States to take the steps that you are asking for to make the cybersecurity strategy all over the country. Because I have been visiting more than 20 countries telling about what they do in Denmark. And when it comes to a certain size, when it comes to a certain amount of inhabitants, it's due to strong regional governance, it's due to strong barriers. So I think your point is quite right. Break down those boundaries.
Yeah. Yeah, I mean, I think that's what's absolutely going to have to happen. And but I think that this the bullet on international collaborations and data sharing, I wanted to bring out a couple of things there because we tend to think about our journey in the healthcare community as just being one of a national journey. That we just need to get our arms wrapped around what's going on in the United States. And I think that, we need to begin to, not begin, but to, because there are people, we've had this conversation, I've had this conversation with several people. There are a number of people in the healthcare space that acknowledge that we are not as involved in international health standards, their development, their use, as we could be and should be. And so that's one of the things. I don't want us to become so domestically focused that we forget about that. Because obviously there are various opportunities in the, thank you. There are various opportunities in the international space for us to share information by necessity. If we didn't learn anything by the SARS outbreak, then we should have learned that we need to be able to share information, and that the world is becoming much smaller all the time. Yes, sir.
So I can put a finer point on that.
Please.
If what we need to do is have devices in the home that are able to interoperate with the electronic health record, we need to work collaboratively with Japan to make sure that those folks that are producing consumer devices have unique identifiers in them that we can integrate into our systems. We need to make sure that we reach out because there are a lot of countries that are ahead of us in certain aspects. And we need to learn from their experiences and incorporate it into our domestic defense. Likewise, if we can get international sets of standards out there, we broaden the marketplace. We provide opportunities for organizations within the United States as well as internationally to compete for health IT technology and advancement. And I think having more international collaboration gets us to better solutions, it gets us to better innovations, and I think it will help us get there sooner. And it's going to require a certain amount of engagement to make that happen.
Absolutely. I mean, does anybody disagree with that point? I couldn't have said it any better.
Unique device identifiers are coming. I was reading something a couple weeks ago that in the next year or two, it's going to be required that your devices have that unique identifier on them. It's going to take a while for the old devices to trickle out of the system, but soon you'll be able to track all of those devices and who's going to be responsible for all this. I don't know, but we're on our way to being able to track all of that.
Right. And so these are things that are happening now, but I think that the future vision, which is the topic today, is the convergence of all of this towards the common purpose that we talked about at the very beginning. reducing costs and improving care and improving outcomes and improving accessibility. So all of these things, and which is actually my point for bringing all of these things up, is all of these things need to be addressed within a comprehensive program that advances towards those performance objectives that we talked about at the very beginning. So I'm gonna go ahead and move on, and some of the things that I want to talk about is, when we talk about leveraging IT, and we've talked about some of these things, so I won't belabor them. Mobile applications, the concept of mobile applications is interesting, but this is also another area where we need to converge on some kind of a standard approach. So we need to have certain types of development platforms that will allow for interoperability across these various applications, and that these things are addressing security in a consistent way, so that we can insert these things as they're needed and as they come up, because there's a lot of smart people out there that are developing applications, and there's a lot of people that are pulling them down and downloading them, using them on their smartphones and things like that. But there's no interaction or very little interaction capability or interoperability, if you will. We need to talk about different types of service-oriented component architectures for various types of IT applications. In other words, there's a service, we do it this way. It's another mechanism for standardizing business practice. I think that what has been done with the eHealth Exchange, which was formerly the Nationwide Health Information Network, I think is an example of some of those types of things that we could do. They now have 28, I think it is, 28? 38 participants in that health exchange, and they can share information back and forth, and they use common services. So this is an example of how we could do things, but we need to do it at scale within the community. Unified communications is about to, it's upon us. Let's face it, but it's now being considered by a lot of communications companies, where you're going to talk about blending network, satellite, mobile communications, so that some of the companies are now starting to provide a brokerage service where, in support of telemedicine, anybody, no matter what their form of communication, can link into a brokerage service. And so now you've extended your opportunities for collaboration using whatever mechanism for communication is at your disposal. So you could, have somebody come in via, a mobile app like maybe Skype if you wanted to, and somebody else using, different like H.264 protocols or something of that nature for communications. I would suggest that we are going to learn as a community how to use social media to our advantage. We're already using it, but I think we're only using it for the obvious things. And I think that as we get into this more integrated, holistic view of how to deliver healthcare, that we're going to come up with other ideas as we exercise our future vision for healthcare that social media can satisfy. And that will mean that we will have to adjust our thinking there. Cloud computing. So here's something. Cloud computing, for those of you that might not know, is projected to grow about 20% annually in the health sector. A lot of that is because of what the gentleman over here was saying, and that is that physicians, like these single practitioner or two doc offices or whatever, they can't invest in the infrastructure that is necessary. But they might be able to buy the service if it was offered at a reasonable price. So that's why you've got folks like Verizon that are investing large sums of money in cloud environments that are intended to manage data in a secure way in the cloud. And so obviously that can be used in the healthcare environment if we get the security right, and it can be used in other areas as well. And I will tell you that, you know, this is not, this should not be a surprise to everybody. We have been building multi-tiered applications across our private networks for years. And so now what we're looking at is these clouds as being the tiers, if you will, and the internet being the infrastructure. And so you're going to have specialized clouds that are equivalent of the tiered architectures that we've implemented in our own networks. So you're going to have a cloud that does authentication, a cloud that provides maybe electronic health record applications, a cloud that is specialized and secured for managing data, and so on. And so you're going to have those types of things evolving, and you're already seeing them evolve now. I just spoke about Verizon. You know, I know that there's a Ping Identity is here, and so they're another example of that. So these are the things that are going to be leveraged in the future, and I will tell you that industry is paying attention to this, and they are looking for opportunities to implement, you know, these types of cloud implementations. I think I'm forgetting to advance. And so the next thing I want to talk about is people, and we'll just talk about this briefly. Healthcare providers. Greater numbers of people in the healthcare system means that we need more doctors and nurses. So you've got things like the National Health Service Corps. There's an investment of about $229 million in facilitating or helping these practitioners pay for their credentialing. And I think that that's a big deal, and there's going to be others that are coming down in that way too. Thank you. Technology workers. We're going to need a large number of technology workers. Just to tell you how important these technology workers are in this current economy, it is projected that the average salary increase for IT workers will be 5.3%. That's huge in this economy. There's going to be they're projecting that there's a 7% increase for network engineers, data modelers, and managers, and portal and web developers. We're getting back into that cloud environment, et cetera. And so, and then there's we're projected to have a 9% increase for mobile app developers. So that tells you where everybody is thinking we're going. We're going towards a more mobile and universally connected. I was going to say disconnected, but you know that depends on your perspective. And then there's also in that array of technology workers, there's a large demand for those that do health information management and telemedicine specifically. So in the future, we're obviously going to advance the use of EHRs, electronic health records. We're going to increase the use of social media. We're going to use these types of things to begin to shift the payment and practice models from treatment to wellness and prevention. Now that's a huge statement because, again, going back to the incentive models and the payment models, I mean, we haven't figured this out yet, but this is what I see as being the direction in healthcare. and then obviously mobility and telemedicine. And I think that we're starting to see some of this shift in the payment and practice models, because we've got the accountable care organizations that are part of the Affordable Care Act. And so we're starting to see some of that thinking being executed. And so I think that that's going to be the wave of the future. Now, in the mobility and telemedicine area, I already mentioned, just want to mention a couple of the great things that are happening here. I already mentioned the medical body area networks and the video collaboration brokers. We're also starting to see an increased use of real-time locator systems that use RFID to maintain track of medical devices and in some cases even patients. And so that's something that's probably going to increase in the future. One of the very interesting pieces that I read was in the area of mental health. There are mental health applications, mobile applications, that seek to maintain some of that patient contact without having the doctor actually have to be physically there. And so I'm really interested in learning more about this, but these are some of the things that I've seen that are starting to evolve that maybe have not been seen before. Integration of voice recognition and dictation software with EHRs. That's going to be a huge advance in the future that'll streamline care in some practitioner settings. HIPAA-compliant texting applications. We all know that doctors and nurses will text back and forth, in large geographical settings or even multiple floor hospitals or whatever. But that's not really been HIPAA compliant. They've done it out of necessity. Now there are applications that come out that are HIPAA compliant for texting. I think it's a company called Cortext, maybe, if I'm remembering right. Does anybody remember that? Okay, there you go. Okay, so these are the types of things that I see coming out. Two things that are interesting to me, not really related to the future vision for healthcare, but are interesting, is the development of medical micropower networks. Has anybody heard about this? This is where you have devices that actually take the place of damaged nerves and provide sensation and function to paralyzed limbs. This is an area that I think is just hugely opportunistic for advanced healthcare and outcomes. And then there's another area that I've just started to hear about. It's called and I know I'm going to butcher this, bioimpedance or bioimpedance. And I'll say it that way because when you think about electronics, electricity, the resistance of electricity moving across a wire has certain characteristics that are based on the composition of the wire. And so when you think about that, the impedance of the electricity going across a wire, that's the similar dynamic to this bioimpedance evolution. It turns out that transmitting signals of some type across the body has a unique characteristic to it for each individual. So now what you can do is you can have an assurance that the information that you might be collecting with a device that's associated with a patient is truly for the information associated with that device is truly for that patient. And I think they've done some studies on this and they're now up to about, I think it's 85 or 90% accurate, and they're refining this continually. But I thought that was very interesting. I wanted to share it with you. So, Do we think all of this will, if we put all of this in a box and we make it available to everybody, will it do these things? I'm going to suggest that it'll go a long way, but I'm also going to suggest that the federal government needs to assist. What if they took a functional view rather than an organizational view to how they do things in healthcare? What if they created a true public-private partnership that was continuous and not opportunistic, where you have this group over here that has a public-private partnership and this group over here? Let's say that it's continuous. And what if we had government programs that were evaluated by citizens and the communities that they served? Now, we're starting to do some of these things, and we've tried this in the past, but I'm suggesting that we institutionalize this. So what would that look like? That would look like this. So the federal government would signal what their requirements and the direction that they are proposing to pursue would be. They would put that out for public and industry group comment. We would get public and industry opinions coming back into the federal IT community. And I'm saying federal IT community because that's kind of my focus. But this could also work in the practice area as well, in the program area. You combine those perspectives by overlaying the public and industry perspectives with any government dynamics that were in play or any other obstacles that might be evident in this particular area in question. And you create a government plan that says, this is where we're going. These are our priorities. These are the things that we have already decided, and these are the things that need to be done. Every industry person that I've talked with has said that if they had that kind of visibility, that they would be able to identify market opportunities that would allow them to invest their own money. Has anybody heard that the industry is sitting on a lot of cash or a lot of liquid assets? Anybody know how much that is? The latest estimate? $5.1 trillion. Do you know how much the entire budget for the federal government was last year? About $3.48 trillion. I think that's the projections are across all industry. So I'm not suggesting that it's only in the healthcare sector. So, but there have been several different projections and analytical studies that suggest that it's about $5.1 trillion that industry is sitting on right now. But I'm not suggesting it's just in the healthcare sector. And so I don't really know exactly what the breakdown is on that, but you know, that's an interesting breakdown. Maybe I can find that for my next presentation. But of that like 3.4 or 3.5 trillion dollars in total government investment or spend, only about 1.2 or 1.4 trillion of it is discretionary. So you can see that and that 1.2 and that 1.4, that's the amount of money that we all, you know, try and get a piece of. Whether you're on the commercial side, whether you're in the states, you know, whether you're at a local government, or whether you're even in a program within a federal entity, you're vying for a piece of those dollars. Now, I'm going to suggest that if we could incentivize industry investments, then they could produce government services that they could then offer to the federal government across a particular sector. And so then what would happen is the government would not have to build this service. Industry has built this service. But now you've also offered them the opportunity, we've offered industry the opportunity to have a persistent revenue stream because they're providing this service to the government that needs those services. And the cost to the government is less because you're leveraging economies of scale in producing the capability and then providing the service. So this is just something for you all to think about. There's a lot of money involved here, but I think that if we did this, every industry person that I've talked with said that if they knew, if they could be sure of the direction of the federal government, that they would be able to identify market opportunities that would benefit their company, the federal government, and the citizens. So, now, we've talked about some of your perspectives. Do you have additional perspectives, or do you want to challenge some of the things that I've said? Yes, sir. Yep. I'm sorry? Oh, I am, yes. Yeah. Yeah. Yep. I think that's. Right. And that's exactly what I'm saying. So I agree with all of this, and since I'm retired, I can be a little bit more direct about this. I will tell you that it is my belief that many times the federal government is its worst enemy. I believe that we have a lot of well-intended program people that are very driven to do the things that they've been asked to do. But they don't all fit together. And that's what I'm suggesting is necessary across the federal government. I'm suggesting that be done at the federal government level, and that all of the federal agencies and all of the programs have a piece of that published plan that they are supposed to be doing, that they are responsible for doing, but all of those pieces fit together so that industry can be assured that what they're signing on to do is what is going to be done and what is really needed. And that at the end of all of this, all of these various things will fit together as a composite whole, which will benefit everybody. And so, you know, some of these the things that I'm suggesting here as market opportunities on the industry side, they might be done within the federal government, but it's the capabilities, it's that piece of this published plan that people need to be crystal clear on. They need to know that if they do X, Y, and Z, that it will fit into this plan, and that A, B, and C will be able to interact with X, Y, and Z. And so that's what I'm suggesting. Yes, sir.
So lately, the federal government's ability to provide much of the vision or clear certainty around anything, i.e. fish on cliff and economic policy, is pretty negligible. So, you know, I'm hesitant to turn over something as important as transformation medicine to a government agency. I might rather let private business continue to innovate and then let the market figure out what innovations fit and are most successful. But, you know, that model, especially with what's going on lately, makes me kind of leery that we're going to turn over the ability to give vision and clarity to change medicine to the federal government.
Well, that's why I'm suggesting that we have to have public and industry input into this, and that input has to be valued and has to be executed. And so this published plan then becomes a composite of the best thinking of this public-private partnership. And you probably can't see it very well, but between industry investments and needed government service, I have a little line that says innovation. And what I'm actually suggesting is that over time, this plan will articulate the foundational things that everyone must adhere to. And then we do exactly as you say, and those foundational things are to foster interoperability and the opportunity for all of these things to work effectively with each other, but that we do exactly what you say beyond that and let industry innovate, because, you know, I have always found that the people out in the audience in industry are typically, you know, smarter than I am. You know, they know some of the things that would be great to do. They just don't know whether they have the ability to invest in moving in that direction because government hasn't provided that clarity. And so I think you're absolutely right, but I'm suggesting that we need a different model for the future, and that a lot of the things that we've talked about today need to fit into that model in a coherent way. And so that's the future vision for healthcare that I see, and that I am optimistic that we will achieve as we move forward. So I think I'm about to get the hook.
We're going to end on that note of optimism, John.
Okay, great.
Thank you so much.